difficult for people, because of where they live, to gain access to fresh fruits and vegetables that's affordable. Perhaps it's difficult because maybe you live in an unsafe neighborhood to go out, or to tell your children to go out and play on the, be physically active, for example. So that's one of the aspects of research that we're starting to look into, and how all of these factors interplay together to influence the disparities that we're seeing.
I see. Mm-hmm. Well, how can this, how can you, be more effective then with the information that you have? Like, how do you reach those groups? You say it might be the communities. Is there anything being done to address those, let's say, hospitals or communities where you can get more information to them? And
well, I can take a crack at that, and Dr. Rhoads can chime in. I think we're at the very early stages of this research. I think the research that Dr. Rhoads and we at the Northern California Cancer Center are doing are fairly state-of-the-art, cutting edge in terms of recognizing the role of the institution and the neighborhood environment and community environment in terms of influencing cancer outcomes. So I think it's the next stage would be to start to work with communities and to start to what we call translate our findings, once we get them, to work with institutions and doctors and community health workers and patient navigators, and to be able to target and hone in on specific groups, and understanding within those specific groups what their specific barriers are. Perhaps within an immigrant community, it might be the fact that they don't have transportation that allows them to get to a clinic. For certain types of treatment, you need to travel to a clinic on a daily basis to receive, for example, radiation for a period of up to 3 months, and perhaps that kind of travel is prohibitive for certain individuals. Perhaps the information that's communicated to them, or the written information that's communicated to them, is in a language that they don't understand, or the language is too technical. Perhaps they're not given the full range of options about their treatment. There might be insurance issues. So all of these are factors that may be issues in certain groups, but may not be issues in other groups. And these are what we're trying to tease out. And then we would translate them to the community and to the institutions.
And I just want to sort of emphasize the importance of really addressing the community where they are, rather than presuming that if we give a recommendation as healthcare professionals that you should stop smoking, you should exercise, you should eat, plenty of fruits and vegetables, that it would just magically happen. Because the social barriers associated with where a person lives indeed may be prohibitive. And I just wanted to actually talk a little bit about a recent study by a colleague of mine who also studies cancer disparities, but is more focused sort of on the patient and the doctor interaction. And one of the things that she's found in rectal cancer is that while using the national cancer data, while whites and blacks are equally likely to have the recommendation to obtain either a consultation with a radiation oncologist or a medical oncologist to receive chemotherapy, those rates are equal. But when you look at the actual receipt of those treatments, they're significantly different, with African American patients being less likely to receive either radiation or consultation with a medical oncologist. And then when she looked at the combined factor of needing both medical oncology and radiation oncology, the numbers were even farther apart. The gap was even wider. So the idea that we should simply give a recommendation clearly falls short under these circumstances, and I think that we do have to begin to understand where the patients are in their lives and in their cultural context that will either facilitate or hinder their ability to obtain the care that is necessary to treat cancer.
So does that mean then you have to look into specifically why, if they've been recommended to get treatment, why they don't get treatment? And that's something that's further down the path that you haven't quite got to yet?
Well, there are very few, I think, researchers now who are really digging into that question. That's relatively new information. Because what's important about it is that the recommendation has been made at equal levels.
I see. Well, how long has this been going? It seems like, cancer's been around for a long time. So I think, well, how come it hasn't been addressed, or how come that issue hasn't been addressed? Or you said it's just something that they're getting around to. Is it just because there's so many different factors, so many things to address?
Well, I think there are so many factors, and I think that's part of the issue, but I also think it's our sort of biomedical paradigm, which treats, and by that I mean the idea that we can connect sort of one disease with one cause. And as I said, watching the migration of the research from 1993 until now, which is a relatively short time, my time sort of in disparities research, but watching that migration clearly shows that initially it was very difficult for the medical institution to take credit or ownership for this difference. And that may have something to do with the hesitance around discussing race issues and class issues in our country. It's not really clear to me, but the focus initially when I started looking into the research was on the patient, and it was squarely a finger pointed at the patient. If you would just change these behaviors, this disparity would go away. And then we started to understand that actually no, the disparity continues to persist despite some of these other issues. So it really is only now that we're coming around to realize that context matters, and I think that in part comes from the development of research methods from the social sciences, which have been imported into medical science research, where the social sciences have been focused on social context for much longer than we have as clinicians.
And I would add to that, one of the problems too is that we haven't had the opportunity to understand completely the full picture of what the disparities are. It's actually only in the past decade or so that we've really been able to pinpoint disparities within specific Asian populations, whereas up until then, Asians were traditionally lumped together, aggregated, because in part that's because of small numbers, but in part it was also because of a misunderstanding of the fact that in fact not all Asians are the same. And so once we start to tease out the data, you do see very striking differences across the Asian groups. With our data, we're able to dig deeper and look at immigration status, and again we see even more striking differences within an Asian group once you stratify by immigrant status. And the same goes for Latinos within this country, is that they also traditionally have been under-recognized as having health disparities, and in part that's because we haven't focused in on them with the data that we have available. If you haven't looked at it, you don't know that a disparity in fact exists. So that's been one of the barriers too.
And I would add to that actually that the recording of race in an accurate fashion in a large data set, in a large database, is relatively, it's critical, and it's relatively new, because a lot of these records will come from a hospital admission. So if the clerk has looked at you and determined that you are indeed white when maybe you are Hispanic, or has seen a surname that looks Hispanic and decided that you are Hispanic when maybe you consider yourself Caucasian, that can also impair our ability to really make comparisons by race. So accurate race coding has really been crucial. And in fact, I would even add that in terms of how the census collects race data has shifted dramatically over time. And I think because it comes from a federal level, it influences the way we think about race in other realms.
Yeah, I think that's a really critical point. Without the data that the people are collecting at the medical facility level, at the census level, we can't do our jobs in terms of tracking disparities in these groups.
So, I don't know if this is a relevant question, but I was wondering, how do you go about then accurately collecting that data from the institutions? Are you forming some kinds of surveys or questionnaires that are a little more accurate with the data?
Well, from my standpoint, which is the data clearinghouse standpoint, the ideal is to have everybody, all of these institutions, collect the data in the same form and manner. We prefer that these types of questions be asked of the patients themselves. But we've also done studies, and we know that does not, in fact, happen. There's a lot of institutions here in the Bay Area, in fact, that don't, in fact, ask this information. And in part, it's because the institutions and the personnel personnel and the staff at these hospitals are afraid that by asking these types of questions,